Welcome back to Lead with Bubba Scott. Today's guest is Dr. Kevin Sullivan, ER physician, former Navy doctor, and someone with whom I had the privilege of serving on a deployment to the Pacific. Kevin has built a stellar reputation as a leader in frenetic environments, both in the Navy as well as in the emergency room. In this episode, we break down the similarities and the stark differences between leading as a staff officer and leading in an emergency medical team. We talk about competence, trust, decision-making under pressure, and what it actually takes to lead with calm and composure when people's lives are on the line. Let's get it.
Lead with Bubba Scott, we're all learning how to lead. We've all got a room to grow. Learn with Bubba Scott from the leaders that we need, from the leaders we don't know.
Dr. Kevin Sullivan, welcome to the show.
Cowboy, it is so good to be here, brother.
Oh, man, you called me cowboy. I have not yet shared with the audience that is my call sign. And I think like every good Marine Corps call sign, it sounds cool, but is actually kind of embarrassing. So maybe later in the show, or maybe it's some date to be determined, I may share what the actual meaning of it is. But rest assured, it's not because I handled the plane like a vaquero.
The audience is in for a treat. I share that story all the time.
Well, hey, we're not here to learn from me necessarily. I like to drop knowledge a little bit, but we're here today to talk to you, a man with extensive experience in the emergency room and operating as a doctor both in the military and outside of it in some of the most chaotic environments one can imagine. So to kick this thing off, tell us a chaotic story from the ER.
Chaotic story from the ER. Gosh, I mean, every day is chaotic, but I think a crazy story that like just got me super psyched and maybe had a happy ending for the patient. So I'll share a story about this time when I was fresh out of residency and I'm working at this hospital out in the boonies. It's remote access. It's tough to get people in and out. We don't have a lot of resources. We don't have a lot of specialists. And middle of the night, in walks this gentleman who is he's a liver failure patient. And, you know, if you've taken care of liver patients before, they're kind of bombs. They really get sick in 1,000 different ways. And so he comes in and he's kind of got some vague symptoms. He's got a little bit of chest pain. And I noticed his heart rate's a little fast. His blood pressure's a little bit low. And he just looks a little bit sweaty. And I'm like, gosh, this guy doesn't look great. So first thing I do is I walk in the room. I throw an ultrasound on his heart. I mean, probably like 5 or 10 seconds into the interview, I've got an ultrasound on his heart. And he's got this massive pericardial effusion, which is basically a big pocket of fluid surrounding the heart. And when you get that, it'll prevent the heart from relaxing. And if the heart can't relax, it can't fill. If it can't fill, it can't pump. And so if it can't pump, you get what's called cardiac tamponade. So anyways, you know, I mean, I throw that ultrasound, I get this huge effusion. I'm like, oh, that doesn't look good. So I'm thinking in my mind, okay, well, I'm going to have to figure out what to do with this effusion. I don't have a cardiologist here at the hospital that can take care of it. I don't have a cardiothoracic surgeon. I'm kind of alone right now. And it's the middle of the night. So the first thing I do is I put a call out to the cardiologist on call. He's a general cardiologist. He says, yeah, like, good luck, dude. I can't help you. And so, like I said before, liver patients can have 1,000 different reasons for being sick, a little hypotensive, a little tachycardic. So I placed a call out to the nearest, tertiary care center down in San Diego. And while I was waiting for the consultation, I got lab tests going and gave him antibiotics because he could be septic. And I gave him, I got a CT scan of his chest and belly. And anyways, I'm watching his heart rate and watch his blood pressure. He's not getting better. He starts tanking a little bit. And at one point you get probably an hour into the time I've been seeing this guy, you got to make a decision. Am I going to stab this guy's heart and drain the fluid or not? Right. And because that's the only way this is getting better. And it's either going to be me or it's going to be a heart doctor down in San Diego. But I don't know if he's going to make it that long. So probably about an hour and a half into the resuscitation, I, kind of made the decision we're going to go ahead and do it. And so this is not something I've ever done before. One time before I had done one before. And anyways, so we go in and, but I'm with a team of nurses. I'm the new guy on the block. I'd been out of residency all of probably 2 months. And we go in with this needle, probably 1.5 feet long. And, is about the, tip of a pencil in diameter. Use an ultrasound and, I was honestly so nervous. I forgot to give the guy any sedation. I just numbed his skin up. And then went right underneath the rib cage and, stabbed right into the pericardial space, right around the heart. And I got lucky. We got it in the right spot. and I left a catheter in place. I think we ended up draining off 700 or 800 cc's of fluid from around this guy's heart. And I'll never forget his face. I took the drape off of him, and you could just see this feeling of relief, like, oh, thank God. I was like, and I was feeling more relief than he was. I was like, dude, you feel better? He's like, yeah, I feel great. I'm like, oh, thank God. His blood pressure comes up. We get him transferred out to San Diego, and yeah, it was a good case, man. It was great because it was right after residency finished up. I was new and I was alone and afraid, and everything worked out for me and him, so it was good.
Holy cow, that is an insane story. And that it happened right
Yeah.
after you finished with residency is wild that you were in charge. But that is such a good insight into the world of an ER doctor, a world with unclear guidance or not a clear path forward. You've got to figure out a plan. And when no one else can help you, the buck stops with you. And we're going to figure out what it takes to get there and then how you go about adjudicating that decision process under stress. So, Kevin, thank you so much for that story. As we begin this show, I just want to point out that you had an incredible career in the Navy serving as a doctor. You've had an incredible career serving as an ER doctor outside of the Navy as well. And we're so lucky to have you here on the show. So with that, could you just go ahead, let us know where you're from and what it was like for you growing up and some of the early
Yeah.
influences on your life?
So I was born in Southern California. I lived here until I was about 9. I was actually the ninth of 10 children. So I got a lot of brothers and sisters. And so when you talk about early influences, you can guess it was my brothers and sisters. I looked up to all of them very much. Learned a lot from them, watched them pretty closely. My oldest sister was about 18 years older than me. And so I had the opportunity to watch all of these, young adults kind of go through life and make different decisions and see how those decisions, what outcomes came from them. And I would say that was probably the biggest, early influence I had. And then I was probably 9 years old. We moved to Colorado. I spent a few years there from until my mid to late teenage years. And then at that time in my life, I would say some of my siblings, they kind of stayed back. And I remember developing a very close relationship with my dad at that time. And he was this big dude. He was 280, 300 pounds. He was a big guy, a lot bigger than me. And he was a powerhouse man. He was a very, very powerful man. And he really loved me a lot. We had a very good relationship. And so he was my leader for sure growing up. And I finished high school up in Washington State and went to college in Montana. And in Montana, I played golf at a school in Montana called the University of Great Falls, and then moved out to California, Northern California for med school, went to Torrey University, California, an osteopathic medical school. And then came down to San Diego, did my residency here, and I've been here ever since.
That's awesome. I think you're on the rare list of people who has me beat on siblings. I've got 6 siblings, 7 Scott kids
The
total.
seven
So
Scots.
you've got me by a substantial
I love
margin
it.
there. Definitely resonates having all those siblings as role models, and then obviously that's incredible. You had that relationship with your father. I wonder, you were all over. I mean, you were moving. I knew that you were from SoCal. I didn't fully understand the large circuitous path you took to get back there, but in that path, obviously you were crushing the ball off the tee, which I'm sure influenced a bit of your decision on where you wanted to go to college. But when did you decide that you wanted to become a doctor, and when did you actually put that wheel in motion?
I did not grow up thinking about medicine at all. When I was in college, I started thinking a little bit about maybe pharmacy, maybe optometry, something, within the healthcare, field. But I wasn't until probably junior year of college that I sort of thought about medicine. And it was just kind of where my interests had taken me. So the first thing I did when I kind of occurred to me that might be interesting was I called up the hospital in Great Falls. I got in touch with a doctor who ended up becoming a great mentor of mine. She was a pediatrician there. And I just went to the hospital and just started watching her work, learning from her. And it didn't take long before until I decided pediatrics wasn't for me. But she took me down to the emergency department, and I'll never forget that day. I walked down to the ER, and Dr. Kevin McCafferty was down just working his shift, and enrolls this old lady. She had lung disease and she came in cardiac arrest. And I watched him put a chest tube in. She had developed a large air collection around her lung that pushed on her heart. Watched her resuscitate her, bring her back, and then walk out of the room like nothing had ever happened. He was just so cool under pressure and never looked back. It was immediate. It was a very, very easy decision for me after that. And so I just started pursuing it.
That's awesome. Yeah, I think two things that really stand out are the development of a close mentor, and how important that is in helping drive the direction in our lives, and then also, of course, that kind of aha moment when you saw someone doing it, and that was the thing that caught your eye. I'm kind of curious. Obviously, you played college golf. I can think of few sports that require more discipline and focus and commitment. If everything's repetition, I can't even imagine the number of swings you must have taken. But I wonder, as you go into studying medicine, obviously people think of that as such a rigorous and lengthy process. Where did you draw your motivation and how did you stay disciplined as you went about your studies?
One of the big things was I just kind of followed my interests. And so for me, I really enjoyed the process. Medical school and residency, I mean, I look back on as some of the best years of my life that I'll probably ever have, really. And it was because I was doing something that I really thought was, I found meaningful. It wasn't painful to put the hours in and do the work because it was interesting and fulfilling. So I think that was really important for me, just having a path that felt like it didn't feel like work. It felt like I was able to do it and feel fulfilled the whole way. I didn't have to focus on the goal so much as enjoy the process. So that was really important. And then, as far as motivation goes, I was married young at the time. I actually got married in college, and I knew that we wanted to have a good life together. In order to do that, I felt like I needed to, you know, to make something of myself, and so I really leaned in on that as motivation for growth and pursuing a career in medicine.
That's incredible, and I think, yeah, just the idea of finding something that you enjoy and being able to tap into that. We've talked about that a little bit on the show of pursuing the things that you are interested in and which bring you joy, and the rest will kind of take care of itself. That motivation will come inherent to the process there. As we think about your success through medical school, finishing up, going into residency, I also know around that time you got involved with the Navy. Can you talk a little bit about what that process was like, the relationship between your studies, the Navy, and then, upon completion of your residency, what that path looked like for you?
I was looking into medicine back in college, and I'm like, gosh, well, I got to figure out a way to pay for this. My goodness gracious. And thankfully, the military offers a pretty good path for that. And so I applied for what's called the HPSB scholarship, and I was able to go to med school as a reservist, and then they kind of took care of the finances piece of it. The choice for kind of branch was kind of easy. My father and two of my brothers were all Navy guys. Actually, both of my grandfathers were Navy as well. So that was a decision that came naturally. And also having spent a lot of time in San Diego, I was like, gosh, I can't wait to get back there. This seems like a good option for that. And the history and the motivation to serve in the Navy was, was enough to say, yeah, this is a good plan. This is a good option for me. I feel psyched for it. Let's do it.
Ultimately, when you finished, what were the requirements? Because you obviously kind of dual hatted, right? Like you did work
Yeah.
in the ER and you also
Yeah.
served in the Navy.
Gosh. Well, so in residency and in med school, the military does a great job of giving you the space to grow as a physician. And so one of the one of the impacts that has is that you then have to lean into the officership piece at as much as you can, and then really try to grow in it when you finish residency. And that doesn't come easy. That's hard. At least I felt it was. Growing into a real, a leader in the military and a good officer it's just really hard to do. And so my kind of path was I finished residency and then was assigned to a Marine unit, Combat Logistics Battalion 15 up at Camp Pendleton. And it was probably as much a growing experience, if not more, than residency. It was just a whole new world, a whole new language, and you're relying on a lot of people to help you out who sort of expect you to be the leader. And so it was a humbling process for me, for sure, because I felt like I should already be there, and I just wasn't. I wasn't the military leader that the team sort of would benefit from. And so, you kind of dive in, and, you put away, you kind of put the doctor hat aside, and you pick up a new hat you've never really worn before, and you try to lean in for help. And that's obviously, I mean, as well as anybody who's in the military, that's where your enlisted leadership comes in and helps with you, helps you to grow because you're just leaning on them.
Yeah, absolutely. Yeah, I mean, having the humility to lean on the people who are surrounding you, to lean on the people who, in a lot of ways, might be your subordinates, but really have a lot of experience that's incredibly valuable. And I think the parallels there are so stark. I guess this would be a question for you. The relationship that you would have with others in the ER, in the operating room, people who over whom you're appointed, but on whom you must rely in order to be successful, and then the same thing in the military, although a less technical requirement in terms of senior enlisted leaders and other officers who maybe they are junior to you in rank, but maybe they do have more experience in different aspects. Since we're talking about it, I would be really interested. You talked about how you did all this studying, you worked super hard to become a doctor, and then all of a sudden it's like, boom, you're a naval officer and you've got all these requirements. And I guess I'm pretty interested in, do you see any parallels between the way that you would work in a hospital and the civilian side and then the way that you had to run a team on the military? Or did either of those reinforce the other?
I think for me, it goes back to like one of these fundamental principles of leadership, and that's just competence. Like, you just got to be competent first. You can fake it to a point, but you got to know your craft. I mean, whatever it is. And that was where I struggled, I think, the most, was because in the emergency department, you have so many years of developing competence before you have to really step into the leadership role. And in the military, it was kind of the opposite. You're just kind of thrown in, or you step into a leadership role at the same time that you're developing the competence that honestly the people around you maybe developed, some years ago. And so I think for me, what at least the thing I took away from medicine as I stepped into a leadership role was at least understanding that piece. That I need to be competent, and I'm not yet. And so really trying to lean into that and develop the competence, the understanding of, hey, how does in this case, how does a marine, a combat logistics battalion run? How does it work? I still don't understand, but I tried.
Yeah. Well, that's such an interesting insight because I think about this a lot when I think about naval aviation as well. I think it's kind of a naval heritage thing where they make you wear big shoes. Where basically like your shoes are too big for your feet and you grow into them. So I always found that in the aviation side of things, it was like, okay, you are finally a good co-pilot. You can finally do everything the aircraft commander needs of you. You can think forward. You can understand what he or
Mhm.
she might be thinking and execute things without being tasked. And then they're like, you're the aircraft commander now. And then before you feel like you're even a good aircraft commander, they're like, you're going to be a section lead. You're in charge of 2 planes now. So you're always, I mean, I remember even like a fundamental thing about flight school was you've flown the T6, this like incredibly powerful airplane for I think 9 or 10 hours. And then they're like, all right, go fly it by yourself. Here's your first solo flight. Figure it out. And it's so interesting to see how that can be an effective means of growth where you get kind of thrown in the water and they're like, you can either swim or sink. It's on you. And I think it's a really interesting and important insight that a way to do that successfully is to focus on the fundamentals and focus on the requirement. You have to be competent before you can effectively, face outwards.
I think that's so true. And one of the, kind of playing off that analogy, it kind of, giving you a pair of shoes that's a little bit too big. I think there's a couple things you learn from that. On the military side, you learn to grow at that pace. And then I think the other thing for me on the civilian side or in the emergency department is you learn that, that the shoes are too big. And that's sometimes I think something a little bit that is easy in medicine to forget, especially as the physician, maybe, is that, I guess just having the humility to say, like, hey, I still have a lot of growth that needs to happen. Sure, I'm the attending physician or whatever, but there's a lot of growth that needs to happen here. And I think I've seen in medicine, there's a humility there that comes from having been in this kind of officer leadership role. You're very comfortable at admitting and acknowledging your lack of competence in a field. And so then when you take it to the emergency department, you're like, hey, you know what? Yeah, guys, hey, tech or RN, hey, you know some things I don't know. Teach me. You got to keep that.
Yeah, that is awesome. That is a I think that is a huge leadership takeaway, just that and we already talked about it, but I think the way you just cased it is so important because you think about some of these professions, some of these highly technical jobs that require critical thinking, decision making in chaotic environments. And you think about people who exude self confidence and kind of the stereotype is maybe, oh, the ER doc maybe is a little cocksure, little arrogant. And I found that to be the stereotype of pilots as well. But one thing that I never understood was like, how can you be
Mm.
an
Hmm.
arrogant pilot when every single time you fly, you do something that you could have done better? Like every time you do a flight, you think about you debrief it completely to understand, even
Hmm.
if you had a great flight, and even if nothing really went wrong, there you were still going to talk about it for an hour afterwards. And so to hear that that's a similar takeaway for you as a doctor is awesome. And I think that for people with whom we work, that's so huge. Like, yeah, you're like you said, the attending physician. Okay, you're the person who's in charge. You're asking for my input. You actually care what I have to say. Now I'm more motivated to work with you. And now, like, I'm excited to come to work. I'm excited to be on your team. And boom, just humility and understanding that self awareness that you still have space where you need to grow can grow within your team and be something that everybody all of a sudden feels excited to be working with you because you're a humble person.
Yeah, I mean, it's so true. I think it's fundamental. I think it's fundamental to leadership, fundamental to being a good doctor, fundamental to being a good officer. I'm sure fundamental to being a good pilot.
Yeah, that's awesome. So we've talked a bit about what it was like to be on the military side. What I'd be really interested is what is it like to actually be the doctor who is in the arena, who's in the ER. So can you walk us through a little bit like what is a day like it's your third day on, X number of days for your ER shift. What's a day to day look like?
Um, Gosh, walk in, drink some coffee, hope nothing crazy comes in the first hour, a minute to digest, catch up with the team. I think that's important. Know who I'm working with, kind of know them as much as I can. Hopefully they're people I've worked with before. Hopefully they're people that that we work well together, and check on how they're doing. And then I mean, depends on the time of day when things start rolling in. But then it's gear up and go. And you kind of strive for that fast, nice, and good, right? Like just be nice to everybody, be fast, don't be the guy that's slowing things down, and don't miss stuff. And you roll. I mean, usually depending on the day, you might see two or three patients an hour would be like pretty standard, but you throw in a couple of sick ones, they might take a little bit of your time, and it does feel pretty busy. It's kind of like if you worked as a waiter before, it's a lot like that. I mean, you're just kind of like, this is my section, they come in, they get bussed, I serve, I put my orders in, they're out, it's a lot like that, honestly. And then, one of the things that drew me to emergency medicine was that, it's pretty high intensity, pretty kind of controlled chaos. You work pretty hard for your shift, but then you get off and you're off, and you leave it at the door and you walk home or whatever. And so that's kind of the day to day. I think as far as you just never know what's going to roll through it. It's almost like there is no standard day. I mean, I've had days where I come in and there's no patients on the board, at 6 a.m. and you get spend a few minutes just to relax. And I've come in and, I've had, a couple codes in the first couple minutes, first hour. And um, so yeah, it's always interesting, man. It keeps you on your toes. It keeps me excited. I drive out about 2.5 hours to the hospital where I work, and I work 2-3 shifts in a row usually. And every time I drive out here, man, I get this feeling as I'm driving out. I spend that 2 hours just getting psyched, getting ready, because you just never know. It's just, we get sick people. So yeah, that's the shift.
Yeah. Yeah, so that's a super that's a definitely an interesting leadership problem. You think about teams, whether it's, a standby line for medevac or a Casovac standby line for pilots, and you know that you're on for 12 hours. You know that at any moment, if something bad happens, you're the team that's going to go in, and it could be anywhere, it could be anytime. That's a serious leadership challenge. So within the context of the ER, you have to, I would imagine you have to have a high performance team. You have to be able to work as a team, and you have to be able to rely on each other, which you've talked about. How do you manage that problem, that constant expectation, or you could be on for 11.5 hours in a 12-hour shift and nothing could happen. And then you think you're about to go home and someone comes in and they need life-saving care. How do you manage that as a leader?
I would say there's a few pieces to that. I would say number one is sort of policies, procedures, and checklists. I think that being able to cognitively offload as much as possible when you're in high stress, high risk environments is really important. You want to have to not think as much as possible. And so I rely a lot on that. In the ER, I would say along that same vein, I rely on pattern recognition. It's being able to pick up early when someone's sick and someone's not, maybe with similar presentations, but something's just a little bit off. And then I would say knowing your team, knowing when to call for backup and when not to. And those are skills that I think I'm still developing that you can be developing that over a career. And I think is really important. For example, I think about my team when I run in the emergency department. I know very confidently that my nursing staff and techs can pretty much handle most any situation that comes through the door, probably even without me. There's a handful of things that I might need to be there to really help with. But man, if someone sick comes in, I know if I'm in the in another part of the ER for a minute, they've got initial stabilization, like they've got it, and I just know that, and I rely on my colleagues, my other physicians, the PAs that are working with me, that are just super competent. It's a team, and you just rely on them. And then I would say the last piece to that is, like I said, knowing when to call for backup, not just within the department, but like when do you reach out for other people? For us in the ER, it's going to be when do you call in, when do you call in support from another specialist who's got a skill set you don't have, or maybe they have a little better than you do. I think number one you got to be able to know, hey, I'm actually out of my league here, and call. But then also not call too early. And I think back to a couple of cases I've had of sort of airway management, sort of airway disasters that I've had. I had a kid one time. He was 16 years old, had a tonsillectomy a couple of days prior. Came in with a post tonsillectomy bleed, and those can be pretty devastating when they open up. The little clot over the tonsillar bed pops open, and if that happens, you can bleed liters into out. And so this kid's 16. He comes in, rolls into. This is just like you were saying. I mean, this was maybe 10 minutes before shift end, and comes in. I just walk by triage, and this 16-year-old kid throws up a liter of blood just right in front of me. And, we rolling back to the resuscitation van. I'm like, well, I guess I'm not going home yet. And I started prepping for the airway on this kid, because one of the things you got to do, obviously, with all that blood in the airway, you got to put a breathing tube in. And, I remember one of my really good nurses at the time, he suggested, hey, why don't we call anesthesia? They're the airway experts. Let's get them in here. They may be good backup just in case. And I thought, you know what? Well, yeah, that sounds like a really good idea. And it's at face value, that's a really good idea. And then unfortunately, bringing another specialist in right at that moment ended up just kind of being too many cooks in the kitchen. And we ended up kind of taking a little bit more time than I think we could have, with an airway that was probably in the end not terribly difficult, that I probably could have done without calling backup. And so I use that as an example because, again, it's like it's not always the right move. Sometimes you got to know when you can handle things. And so yeah, I go back to, I would say, checklists, policies, and procedures, cognitively offloading, having a team you can trust, knowing them, and then knowing yourself and being able to trust your own training. I think those are the ways that I manage the stress of the ER.
Man, that is a absolutely nutrient dense leadership guide that you just dropped for a chaotic environment. A couple of things, just going back to that baseline, like competence. You have to be competent, and you have to understand your limitations. I think that's huge. I think that your example of bringing in that specialist is so interesting. A lot of
Yes.
leadership frameworks talk about sometimes a 70% answer executed right now that you handle right now is better than the 99% answer that you'd get tomorrow. That's certainly something they talk about in the Marine Corps. It's certainly, something talked about in a lot of different frameworks. I think what's interesting about that within this context is that you're talking about someone's life. So I think the pressure on you, we talk about chaotic environments, we talk about high intensity environments. I think there's nothing is more intense than handling someone's life like that. But it is so interesting that, the fog of war, for lack of a better term, the chaos that can ensue in these scenarios, um, can create a little bit of doubt, or perhaps, like, how hard is it to tell someone, no, we're not going to call in the expert on this area. That's a leadership challenge as well. And I think you can only do that if, like you mentioned, you've built that rapport with your team. But it is absolutely an important insight that bringing in, like, sometimes trying to get that extra 5% of information to be 100% sure about your decision, it certainly stifles tempo, and in a life-saving environment that can be critical. So that's really an important takeaway, I think.
You want to take the advice of your team members, take the input of your team members to maybe call in a specialist. But yeah, what a leadership opportunity that is, where you say, no, we've got this, guys, we've got this. Like, I trust you, and you can trust me.
Yeah. Yeah. Well, yeah, that's such a huge point because, I mean, on two levels. One, it's basically taking ownership of the decision. At the end of the day, if you're the doctor running the ER that day, it's all on you. All of the decision making falls ultimately on your shoulders. It's much like command, where there's nothing after you and there's nothing before you. It stops with you. It is your ownership, your responsibility. It's on you to make the decision. So you synthesize the advice you get from your advisors and the input you get from your team, but ultimately sometimes you have to tell them, like, thank you for your inputs. We need to do this other course of action, and it's my call, and they need to be professional to respect that. But then on the other side of that, like you said, how can you message to your team that you trust them more than saying, we don't need that next echelon? I've seen you at work, and I think we can handle this life saving problem as a team together. And then you do it.
It's so true. And gosh, as you're talking, I mean, the person that's coming to my mind you know, was our commander for the MEU. I mean, what a guy that could just synthesize information from all the people that were around him. And man, he knew when to say yes and when to say no. Like, he was just so good at that. And I think that's what made him such a good leader. I mean, the thing about it, right? And you kind of touched on it a little bit. Like, how do you say no? How do you say no when when someone's got a good idea, And that's, I think, another piece to that leadership challenge in the example I gave is that, what's the right way to respond? Colonel Diane was so good at that. He just, even when he said no, he didn't make you feel bad. And it was such an important part of leadership, was that just that sort of respect for your recommendations, even though, he's like, I'm taking it in and I just gotta, we're gonna do something different this time.
Yeah. Yeah. No, absolutely. And I think, so just for everyone listening, the is what Kevin and I serve together on. And we've talked about a little bit before, but that's when you get a huge team from the Navy together and a huge team from the Marine Corps together, and you go and deploy. And a really important aspect of this is that there are two commanders, one who's in charge of the Navy side of things, that's the ARC, and one who's in charge of the Marine Corps side of things, and that's the And why I think this is such a important thing to consider is that I can't really think of a bigger example of a staff than a staff. So this commander that Kevin was talking about, he's got he's got dozens of people on his staff, all of whom have to give him advice, and all of whom have to give him their inputs before he can synthesize them and make a decision. And if you want to talk about someone who could be paralyzed by information, or analysis paralysis, as people like to say, it's absolutely someone in that man's shoes. And when you think about this problem set, the greater the access you have to information, the greater the temptation to take your time and make a deliberate decision. Of course, we always want to be deliberate in our decision making, in my opinion, but deliberation has to be different based on different circumstances. And so the amount of training required just to get the MU commander staff capable of processing information and giving him recommendations is immense. So when we talk about it in that context, I think it's really wild. And then you shrink it down to these smaller but still the team's operating in dire circumstances. It absolutely, that's such a great insight, that experience that you had. And I think your takeaway is really positive to think about, hey, like ultimately we were able to get this person the care that they needed, but we could have been more efficient. And in something like an emergency room, efficiency, I would imagine, is critical.
Yeah, it was, and I'll be honest, that was, I look back on that case and man, we were lucky. We were lucky that he did okay because it was a real hairy situation, and it took a long time to get that our way.
Yeah, no, that sounds really crazy, and but I think it's so important to look back on that, and then also to have that conversation with your team later. Is that something that you guys do in the ER? Like at the end of a shift, do you talk about the things that went down that day, and do you debrief at all?
Definitely best practice. I won't say we always do it. I think in general, if we have a bad case, you talk about a pediatric arrest, something like that, especially one that's gonna either it's gonna stick with the team for a long time, or there was something, because of emotional factors surrounding it, or if there was something real unique about the presentation that we don't necessarily see too often. Yeah, a debrief with the team, will definitely take place, and it'll usually takes the form of having a member of the team kind of, as you kind of gather together, kind of share the case kind of through their eyes, and what the highlights were that they saw, as far as kind of how things played out, and then sort of just kind of some recommendations from the team, and always with the goal of really sort of understanding systems based issues that can be better. Right? Where was the equipment? How did things run? How can we improve this process to make this run smoother the next time and maybe get even a better outcome,
Mm.
than we had. Um, which really I think goes into a lot about just leadership in the emergency department. Being a good doctor is kind of like, it's caring about the patient in front of you and being able to give them the best possible outcome emotionally, physically, spiritually that you can. And then being a good ER leader, is being able to care about the rest of the patients that come after them and what happens when you step out of the ER. It's about paying attention and caring enough about the processes surrounding each patient encounter so that you can achieve, the best outcome time after time. And I think feeds into that discussion of debriefs, right? And the importance of debriefs is that it's that improvement in the process. So it's the care it takes to be an advocate for positive growth.
Yeah, no, I mean, there's so much to take away from that. I think it's you really get to an aspect of ER leadership that I certainly have not thought about before, which is that yes, it's your duty as a doctor, it's your oath that you've taken as a doctor to give the best care possible to each individual and to create the best outcomes for someone in need in that in a degraded health status. But then how as the ER doctor and as an ER team, you cannot dwell on those things that have just occurred because there are more patients coming in who need more care. And so it's really incumbent on the team to create the most repeatable, predictable processes that allow for you to not focus on getting the person off the litter and onto the bed, or these tiny things that individually could, like you said, take a lot of cognitive space. You try to do cognitive offloading. All those processes and procedures need to be in place so you can whittle down and focus on the isolated issue that's preventing this person from being healthy. So your debriefs would be so focused on how to improve your processes. But I do want to ask, so many people, I mean, personally, I know seeing some of the things that you must see in the ER must take a tremendous emotional toll. And I think about the nurses who are and even the people up front who are just bringing these folks in, the first responders who are bringing these guys in, and then they get to the ER and just time and time again dealing with traumatic injury and seeing people at the worst moments of their lives. How do you as a physician handle that? How does one engage in that profession and maintain your ability to continue a day to day? And then how do you manage that for your team?
I think the first step, and probably the part that honestly for me probably took longer to figure out, is actually taking the time to notice what it's doing to you, if that makes sense. It took a while because you just, you go and kind of go through the process. You almost sort of lose that sense of this is a human life. Like this is like me. This is like my family. And it's not, you gotta pause it. I mean, I found I have to pause regularly, and especially when I have a bad case, and think about that. And once I notice it, once I allow that to take some emotional space in me, I can sort of process it a little bit and reflect on sort of my own vulnerabilities, my own values, my own family. And then once you notice that and you process it a little bit yourself, you can actually take care of your team. That's when I think you can notice the impact that it's having on them. And I look back to a couple of mentors I've had who have helped me with that very, very personally, because they were physicians that sort of understood that on a pretty deep level, and they brought that to me. They reached out to me when they just noticed, like, yeah, something's a little bit off. I remember one time when I was an intern, a mentor of mine who was a pretty young physician, but just a very quality individual, great physician, very competent, great man. He saw the struggle, and he sent me an email like the next day to check in and just say, hey, how you doing? And it was you could tell he was a guy who had noticed it in himself and to he took the time to process himself, and then he gave of himself to me, and it was really special. And then I remember another time later in my career when another mentor, right as I had finished residency, he was at that point, he was very much a mentor of mine, but we'd stepped into sort of a similar role as attendings. And he noticed something was just, hey, you need to process a little bit better. And he reached out to me, and I asked him later about it because he was a mentor to a lot of physicians, probably, a lot of people. And, he just told me, I asked him, how did you notice? I mean, what made you reach out? And he just said, he just asks people regularly how they're doing, and he just tries to listen.
Mm. Yeah, that's huge. I think that's really powerful, and I think it's so important, to acknowledge those moments when that mentor made the impact on you, and then to think about how you take those moments from these mentors and then you put them in your leadership suitcase. So when you're in those leadership positions and when you have your own people that you look after and you look out for, that you can do the same thing and pass it on. I think this is a really interesting insight you have because I think that it's very human. It's almost like a part of the human self-protective trait to compartmentalize when I would imagine, after a certain point of being exposed to trauma like that, especially physical trauma that is so visceral, and I think a lot of people have a really hard time interfacing with. Doing that professionally, you basically have to compartmentalize and you have to it's kind of like in aviation, there's always a risk that like your plane just comes apart, and if you start thinking about the plane coming apart, you're doing a bit like you cannot spend time thinking about the plane coming apart. It could happen. It has happened. You cannot think about that happening. Of course, you can be processing threats, risks, projecting forward what your response would be. But as soon as you start thinking about the uncontrollable situation like that, it can be debilitating in the plane. And I think that that's a protective thing that we do as humans, just subconsciously, that you would compartmentalize these traumatic experiences that you're seeing. But I think it's really powerful that you had those mentors who noticed when it does when your cup gets a little bit too full. And so then systematically, like developing a system to acknowledge and to take that step back and to be able to say, okay, like, yes, when I'm in the operating room and I'm conducting the surgery or whatever it may be, like you're not thinking about it the same way as you might later in the day when you have, you have some time, you have some space. Because there's one thing that I do believe is that yes, it's a tremendous skill to be able to compartmentalize, but if you never take that time to step back and do some reflection on some of
Yeah.
these things, it can build up and become overwhelming. So I think it's awesome that you had mentors who pointed that out to you, and then that you built that into your battle rhythm of like doing kind of a self check-in and checking in on your team to make sure that they're doing all right as well. You've done a really good job of describing the two worlds that you operated in, one as a naval officer and one as a doctor. And we did kind of tease out some of the things that made an impact, like the things you learned as a naval officer that impacted as a physician and vice versa. I would be interested if you could just reflect on those two experiences.
I mean, I go back. I think the thing I took from medicine to officership is competency, and the thing I took from officership to medicine is humility. I just don't. They were such different roles, and they just really, really, in a way, they were. I mean, they were because they were so different. They complement each other so well.
Yeah, no, that's huge. Okay, so we're coming up on time here. Just got, my final question I ask every guest on the show. If you had to choose one leadership trait for a young aspiring leader to cultivate going forward to help him or her be successful, what would it be?
Empathy. I think that it's empathy. I think that I think that if you really care about your team, if you really care, I think they'll care about you. And if you have a good team, you'll be good. Then the team will perform. So I think you learn so much through empathy. And I think that as a leader, you just have to be constantly learning from the people around you. I don't think you can do it without really empathizing with them.
Yeah, and I think that is a straight line through everything we've talked about and all the leadership traits that you talked about on your path and your path from building competence to being humble, and how do you marry those things? I think a big part of that is empathy. So I think that's really well said. So just going forward, is there anything in the next, few weeks that you've got going on that you're really excited about? Any major events with the medical practice or anything like that?
I start a new hospital in 2 days, so that'll be interesting. Um, I Yeah, I'll be working at a new place, and just as a part time in addition to kind of my regular gig. It's 10 minutes from home instead of 2.5 hours, so I'm looking forward to doing that a couple shifts a month.
But yeah, well, Dr. Kevin Sullivan, thank you so much for coming on the show. It's always great to see you. Great to reminisce about some of the times we experienced aboard the ship, much of which we did not share. There are many conversations we had late at night off in some dark sea somewhere that won't be shared on the airwaves. But thank you so much for taking the time sharing your leadership perspectives from the ER and in the Navy as well.
Yeah, it was a pleasure, Cowboy, and I'll be listening to future episodes, waiting to hear your version of where that infamous call sign comes from.
We'll see, or maybe we won't.
Stay classy.
Thanks so much for listening to Lead with Bubba Scott. This episode was recorded and edited with Riverside.fm. Theme music developed with Suno AI. If you enjoyed the show, please follow and leave a review wherever you find your podcasts. And be sure to follow us on Instagram at Lead with Bubba and let us know your thoughts in the comments. See you next time.
Lead with Bubba Scott, we're all learning